The next person that we're going to hear from is Debbie. And Debbie, I think, as a mother of a 17-year-old who was diagnosed with AML, had to make some of those tough decisions and had to help a teenage daughter, which is hard enough, make those kinds of decisions. So I'm going to ask you guys to take your seats and sit back down again. And we're going to get to hear Debbie's story. Mm-hmm.
All right. Good evening, everyone. My perspective is a little bit different in that I'm the mother and caregiver of an AML patient. My daughter, Courtney, was 17 and a senior in high school when she was diagnosed with acute myeloid leukemia. She was treated here in New Orleans at Ochsner by the Pediatric Oncology Group for about 6 months. We were in and out of the hospital. She had intensive chemotherapy. At the end of 6 months, it was by that time November of 2004, she was declared to be in remission. We were thrilled. She went back to school half days, joined her friends in doing things she had been missing, was trying to get back to normal, and unfortunately 3 months later, in March of 2005, she relapsed with AML again. So we were devastated, and we were told by her oncologist at that time that she would need to have a bone marrow transplant to save her life. We were unable to find a match in our family or community or the nation. We did a bone marrow search, could not find a match for her. So after some research, we decided to pursue an unrelated umbilical cord blood transplant. We went to Duke University Medical Center for this, to Dr. Kurtzberg, who is a pediatric transplant physician. We were in a whirlwind once we got this news. We had to research which transplant center we were going to go to, had a lot of decisions to make, had a lot of things to do to get ready to leave our home and go to another state. Duke is located in Durham, North Carolina. We ended up spending 9 months there. We went up to Duke. Of course, in the meantime, our oncologist had mentioned to us that this might be a time to pursue or to at least look into fertility preservation, that he didn't know if that was even a possibility, but that possibly we should get some advice from a fertility specialist. We went to one doctor in New Orleans before we left and got some information. Luckily, I'm a librarian, so I'm used to doing research. And I got on the computer and did a lot of research, located Livestrong's Fertile Hope organization that's been mentioned several times tonight. That was invaluable to me. I printed out stacks of material and studied it and read it and learned about all the different options. So we went to Duke. We met with Dr. Kurtzberg, the transplant doctor. Of course, we had a lot of things to do to get ready for the transplant. I mentioned the fertility issue with her, and she said, well, of course, our first priority is to save Courtney's life. The transplant is scheduled for May 12th. She said, we have 3 weeks before then. Whatever you do, go for it, but it's got to be done by May 12th. We cannot postpone the transplant because it would risk Courtney's life. So we went to a fertility specialist there at Duke who really told me exactly what I needed to know. She was a lifesaver. I told her that I was unsure about what to do. I didn't know if I should put Courtney through this or not. It was going to be a very difficult thing to go through preconditioning treatment for a transplant at the same time she had hormone treatment and an egg harvest. Dr. Couchman, what's her name at Duke, the fertility specialist, she looked at me in the eye and said, "Debbie, I have 2 daughters. If either of them were going through what Courtney's going through right now, I would do exactly what you're thinking about doing." And that just meant the world to me, that she spoke to me as a mom, really, not as a physician. And from that point forward, I knew, okay, we're going to go for it. We're going to do this. So at that time, the egg harvesting and freezing was, I would say, borderline experimental. It wasn't done a whole lot. It wasn't done in very many places. The center that I located to do it for us was in Atlanta. They did not do it at Duke at that time. I think that has since changed and that they do now. But we had to, of course, I was in the center of it all, coordinating all of this treatment with 3 different doctors. Dr. Kurtzberg, our transplant doctor, the fertility specialist at Duke, and then Dr. Mitchell Leaf at Research Biology Associates in Atlanta. And our routine was every day we would get up in our little hotel room across the street from Duke Hospital, go over about 8 o'clock and get labs drawn for her transplant doctor, get on the tram and go to another building, medical building on Duke's campus where the fertility specialist was, have labs done there and a vaginal ultrasound done there, go back to the hotel, fax all those reports to the doctor in Atlanta. She would fax us back orders of what to be done, what dosages she needs, what shots she needs, and all that. And she would give herself shots in the hotel room. Of course, you probably think, wondering what Courtney's feelings were about all this. She's 17 and turned 18 during this time. And luckily, she is a very easygoing, go with the flow kind of person. And at that age, she really hadn't thought about what it would mean not to be able to have children. She had never been thinking about having children yet. She wasn't old enough. But she could tell that I thought it was important. And she trusted me with a lot of decisions, and she trusted me with that one. So she went along with it as hard as it was. We went through 3 weeks of the fertility treatments. Then we got in the car, loaded up all her medicines and medical equipment that we needed, drove 7 hours to Atlanta, stayed in a hotel there for about 3 days, had the egg harvest done. It went successfully. The doctor was able to harvest 19 eggs, and they are now frozen there at RBA and ready for Courtney whenever she wants to try to have a family. It was a very challenging thing, but we're glad we did it. Some of the problems and challenges were that we were kind of on our own, we felt like, to do this. There was nobody telling us really what we should be doing. There was nobody coordinating it for us. I had to do most of the coordinating, and I think it would have been difficult even without the transplant process going on simultaneously and a line infection going on simultaneously where we had to give her IV antibiotics in the middle of all this, deal with all the emotionality of the hormone treatments. It was just very difficult. And I think if there had been a team of doctors that worked together instead of through me, it certainly would have made it easier for me. The cost, I can only tell you what the cost was for us. I'm sure it's different at different places. It was a $15,000 charge at that time. This was 8 years ago. Insurance paid maybe a few hundred of it for some of the diagnostic tests. We wrote a check for $12,000 when the day of the egg harvest. It was required up front. We did get some of the hormone drugs donated which was a suggestion from a nurse that I was just talking to in the waiting room one day. She said, have you asked about the drug company donating some of the drugs? And I said, no, I never thought of it. So I just asked the next day, and it happened. I didn't have to fill out any paperwork or anything. The drug company donated some of the drugs. Of course, that was just maybe a few $100s too, but every little bit helps. We pay $500 a year for her eggs to be stored. So I don't know how that compares with other places, but that's what we pay. One of the challenging things really about it too was, like I said before, the time frame. You find out that you've got to make these decisions, and you've got to make them really fast. And so that was very difficult, having 3 weeks to make a decision quick and then to get it all done. Very difficult. One regret, probably the only regret we have about the whole process, is that we didn't think of, and nobody suggested to us, that we visit this issue during her remission. Because looking back on it, that would have been the best time for us to have fertility treatment and harvest her eggs, would have been those 3 months she was in remission. However, as far as I'm concerned, I was trying to be optimistic. I was thinking, yay, she's cured. She'll never have this again. We're over this. You know, it's done. We're moving on. So in order to be optimistic, I didn't even want to think that we needed to do anything like that, or that she would possibly get sick again. But I do wish that a doctor or someone had said, you know, just in case in the future she should ever relapse or get another kind of cancer, which she would be at higher risk from because of the treatment, maybe you should think about doing this. But that's easy to look in the rearview mirror and think of these things. But that would be my only regret. We are very, very pleased, and Courtney's very pleased now because now she's 26. She's old enough to appreciate her life and the fact that she can possibly have her own children someday. So she's very excited that we went through what we did. And we know the chances are small that these eggs might result in a viable pregnancy. We have been told anything from 10% chance to 25% chance. But we know as time goes on, medical technology might be able to get to the point where the chances go higher than that. So we certainly hope so. Thank you.
Thank you. Sissy?
And I think that the technology has brought things along a little bit since then. When you look at the chances for one egg to end up as a pregnancy, as a baby, that chance is somewhere between, of the studies that are coming out now, that chance is somewhere between 5 to 12% per egg. So with 19 eggs, so that sounds, you know, very, very hopeful and very exciting. Yeah. I would like to add that in the little folder that I put together, we looked at different costs, called up different programs, and so I do have some information in there. And I think the costs are coming down, particularly with egg freezing. So right now, the same program that you went to is now offering freezing for $7,000. So the stimulation, the retrieval, and all that for $7,000. But when you're looking at costs, you really have to be careful because there are a lot of different ways for the cost to be listed. You have to consider what the long-term storage costs are going to be. And there are also facilities in the U.S., all they do is store eggs, embryos, sperm. And their long-term storage costs may be less than the program that you had the eggs or the embryos frozen at. But those costs have come down as well, and I suspect that they will continue to do that over time. So.
Great. We have two more survivor stories that are going to be shared. One's particularly special for me because I've had the experience of taking care of a woman who got chemo while she was pregnant once or twice before in my life. But before we go on to that, are there some questions from the floor? I think we have some cards. There's some cards. There was a question that was asked before we started that said, somebody wanted to know what and this is probably for Rod or for Sissy, what's just the general risk of having fertility problems in your life without chemo? So what's the background risk? So for somebody that, so the point is that if you've gotten chemo, I think the point behind the question is if you've gotten chemo, you may have a chemo issue that's related to infertility, but everybody has a background risk of infertility. So that's what the question's about.
You have a mic, go ahead.
I get it to work. That's really based on age. So overall, if you look at all ages, it's about 1 in every 10 couples. But it's lower in women in their 20s and much higher in women in their 30s and 40s. And I think that's the other thing that it's a great question, because the success of preserving these eggs or these embryos is going to be related to the age that the woman is, that she's going to have these procedures done, and what is called ovarian reserve. How healthy are her ovaries? How many egg units does she have left in those ovaries? And that can vary quite significantly from woman to woman. We know that there are standard numbers of eggs per millimeter square in the ovary. For example, in a woman, a female that's under 7 years of age, there are about 20 of those units per millimeter square of ovarian tissue. When you get to be over 15, it goes down to 1. And you can imagine what it is when you start hitting your 20s, 30s, and 40s. So the answer to the question is it's related to the age of the person more than anything, as far as the background infertility or fertility rate.
Yeah, and to go along with that is that there may be a premature loss of eggs in women who've undergone chemotherapy. So, you know, even though the egg itself may not have been affected by the age, but let's say if the natural age of menopause is 51, it may be 40 or even 35 in someone who's gone through chemotherapy. So even the spontaneous conception rate may decline, you know, after cancer therapy. So one other issue that I just wanted to bring up that we didn't address when we talk about some of the ethical issues in talking to people is the patient who's gone through fertility sparing, or let's say cryopreservation of either gametes, sperm and eggs, or embryos, and they don't survive. So one of the other issues that we have to sometimes, and the patients have to talk about, is what disposal of those embryos or sperm and tissue, or tissue, what do we wish to do? So it's very important that they have thought clearly what they'd want to do, because we know, and many times, unfortunately, these cases are decided in court because someone has died and they've left frozen sperm, and now that family wants to use them, you know, or an embryo. So again, just other issues that you have to address.
We're going to go on to Zane. And Zane was diagnosed when he was 24 years old, and I believe his wife was pregnant at the time that the diagnosis was made, and he's going to tell us his story.
Yeah, I was 24, 22-year survivor right now of AML. At the time of diagnosis, I hear all these stories of people talking about, you know, what it is, and you're trying to absorb all this information. I remember back then, we didn't have the internet. There was no cell phones, Googling, or anything like that. And I still remember the doctor telling me, you know, I had leukemia. And all I could think in my head was sickle cell, because that was the only blood disease I ever knew, because you always saw the ads on TV. And couldn't figure out how I could have sickle cell. And it was just being ignorant of what leukemia was. So initially, the concerns were, I mean, I don't know what they were because I was overwhelmed. My wife was pregnant, 6 months. Next thing I know, I was at MD Anderson, told I would have to have a bone marrow transplant. I show up, a wreck, basically just pouring out to the doctors saying, I've got to have a bone marrow transplant. You know, he comes shuffling in. He's in sandals and T-shirt and a lab coat. He smelled. And so he told me, sorry.
That was confidence building. I think
But,
I'll change my outfit tomorrow.
Well, they just, I mean, I'm looking at this guy, and so he's telling me, no, don't worry about it. We think you're young enough to take it. So I said, all right, and, started treatment. They hit me 4 times with idarubicin and Arac. I was put in remission right away, but what had happened, they came back soon after the first treatment, hit me again, I think too soon. And my bone marrow was pretty much dormant. There was nothing for like 62 days. So then after that, around day 63 or 4, I get a bone marrow test, and they found one little thing. And then after that, it started coming back up. But the concern there for me was I sterile? Because of all the treatment I went through. And I was kind of told, yeah. But in April '93, my second daughter was born. And so I remember calling up my oncologist and yelling at her. I thought you said I had no bullets. And so, but also with regard to my first daughter, my wife was 6 months pregnant at the time, and I'm thinking, well, doesn't she have the same thing I do? Because it's so close, from the time of, conception to my diagnosis, only 6 months. So I thought maybe I passed something on. Well, she's 21 now and perfect health. My second daughter, I'm thinking, well, everything's still in my body. Because I remember it felt like 4 years before my skin even felt normal. Because I couldn't take Band-Aids at all when I was in the hospital. Whenever they would peel a Band-Aid off, my skin would come. And I hated that. So I thought about my second child. And she's fine. She's 19. She's going to interview for LSU nursing school next week. And then I have a younger daughter who's 13. So fertility, from my point of view, initially was a concern, but it was also, something at the time of the, being diagnosed, something right after all this chemotherapy, because what they put into you is horrible. And then years later, what's the, fertility issues down the road? Also, my other concern is, the doctor's only there to get you through it right there. And they always tell you, you're going to see an oncologist for the rest of your life. And I'll tell you that's true. I see my oncologist every year. Just go in, walk in, out, but the one thing they don't tell you and they're not prepared for is, like, what about all the other stuff? What happens down the road? 22 years later, I'm still trying to find out stuff. And I don't know if I'm just getting old, if there's something else. But I'll tell you one thing. I do have what they call survivor's guilt, because my youngest daughter, her best friend got diagnosed with leukemia. It took me a few days to get ready to go see her. It's that difficult. It's just, I walk into a hospital, I remember everything. I can remember every part of my treatment. So it's difficult, but it took me a long time to come out. So I know we're cutting short on time, but I think my purpose here is to, let people know that you can survive 20 plus years, especially with AML, which is pretty brutal in itself. And you know, there's things you got to think about down the road. You know, whether it's financial, mental, everything, family. Because I'll tell you, it's the most difficult on the family, not the patient. Because you know, my wife would not leave my side, and she was 6 months pregnant on a cot. And anybody's ever been in MD Anderson knows those rooms are small. So I'd like to thank y'all. If you have any questions, I'll be here.
And I want to say last but not least, but we're going to hear from Sarah. And so Sarah was diagnosed when she was 20 weeks pregnant. And I've been on the receiving end, actually, of caring for some pregnant patients diagnosed actually with breast cancer. I don't think I've taken care of anybody with lymphoma, but the misinformation and the disinformation that's out there about what treatments you can actually use in pregnancy or not, it's pretty incredible. So I've been looking forward to hearing your story all day.
Well, thank you. That makes me more nervous. I'm not a professional speaker. I'm a professional mom now, thank God. But my husband and I tried to get pregnant for a very long time, and I got pregnant. I didn't believe it. I took 7 pregnancy tests, and my OB said that was a record. And we were so excited, and everything was going along fine, and I started to have problems breathing. Well, they thought that it was heartburn, but it progressively got worse and turned into a 2-week fever, and they thought that it was pneumonia. But luckily, my primary care was very smart and very careful, and he sent me to an infectious disease specialist who, that's the doctor you want to see when you're pregnant, by the way. You know, I was scared to take Tylenol, but I had to go see an infectious disease specialist. Anyway, she did a x-ray of my chest and found that my lymph nodes were swollen, one of them so swollen it was about to cut off my airway. They biopsied my left axillary. See, you learn all these things whenever you get cancer. That means your armpit. Like Laura, it's a learning curve. You learn to talk in very strange terms, but they had mentioned cancer, and I just, you know, that couldn't happen. You know, I'm pregnant with my first child, and that's just too horrible for words. Well, it came back, and it was, you know, lymphoma, and my first thought was this because I smoked in college? I was, you know, 30 years old, just turned 30, and it was quite frightening. Every doctor I was scheduled immediately to go to my first oncologist, and he was. I felt like I was more educated than he was, thanks to the Leukemia Lymphoma Society. We lived on that website, but within 3 days I saw him. Everyone wanted me to start treatment immediately because they were worried that the golf ball size lymph node was going to cut out my airway. But he and I didn't really agree on what I felt was the best treatment, so I went and saw a second oncologist. This is all within a week. And the second oncologist recommended I go to MD Anderson. He said that it was possible for me to keep my baby, and that it was possible that she would live. And I went and saw a maternal fetal medicine specialist. I had a lot of doctors because everyone was being so careful. And the maternal fetal medicine specialist scared me to death. I will have to tell you that, and I want to share that because they were asking about what she would do differently. The doctor really went down the list of drugs, and my favorite drug that I got was called the Red Devil. I mean, it's like, oh, wow, thanks. Can you keep that to yourself? It's called adriamycin, and they have to worry about the baby's heart, and they thought that the baby would spontaneously abort. Well, all of this, and within a week, this was a week before Christmas, we went to MD Anderson, and they confirmed my diagnosis there. But when I got to the oncologist, he was more worried about my postpartum depression than he was worried about the baby's health. So you can see the difference in knowledge, and like you said, people were it's coming back, where people are starting to learn more and what can happen. My favorite study is there's an 18-year-old in Brazil who had the same chemotherapy that my daughter had to undergo. I saw my fourth oncologist because I decided to move in with my mom in Baton Rouge, and I found an oncologist there who I was his sixth pregnant woman, and that made me feel much better. I was his first lymphoma, and he took really good care of me. I was diagnosed on December 1st, and I started chemotherapy on December 26th. So I only had 25 days to take in all of that information. I cried the whole time because most of the doctors had told me that I was killing my child. But anyway, I mean, I'm 4 years out, and I'm still dealing with all of the trauma of it. I did see a fertility specialist while I was at MD Anderson, but not for the exact reasons. Fertility preservation wasn't an option because I was pregnant. There was no way to harvest anything. So my husband and I had already decided anyway that we would adopt if I lost the baby. Anyway, I entered Meg and I into a study. I'm number 106 of pregnant women who went through cancer, and they take Meg's reports and all of my reports. Well, obviously, I am the mother of 2 children, and I had Meg will turn 4 on March 29th. I'll be 4 years post-chemo and clear in May, and I'm very blessed just to even be saying that. When you do go into this chemotherapy, and the one thing that I would say is that you're getting so much information, and you're trying to arm yourself, and you're trying to make the best decisions possible for your life, for your child, for all these things. I mean, and mine was both of us. And I didn't want to take the chemotherapy, but they told me that Meg wouldn't. She was only 22 weeks, and that her chances of them being able to take her early, and then we worry about my chemotherapy, she wouldn't do well. So they said that this was the best option. And like Zane, I will always have to worry, if she cuts her finger, she does, anything that it has to do with it. But she is a beautiful, hilarious 4-year-old. She loves strawberry shortcake, and she's absolutely wonderful. And all I can say is that, it's so important not only to educate on the good things, but the bad things. Part of survivorship is learning to live with your decisions that you made. And you have to learn. And I mean, every day of my life, I will still think that I hurt her in some way. But I didn't. I did what I had to do and what I thought was best, and I made the best decisions possible. And the one thing with fertility treatment is that you're already so emotional, and then you throw the fertility on top of it. And when someone tells you that you can't have a baby, it's just like telling you that the baby inside you is going to spontaneously abort. And you're already so emotional. My one concern with all of this is that we're taking in the whole person, not just the fertility in the end, but how that person's going to deal with that decision in the long term. Because like Zane, new stuff comes up all the time. I itch. I constantly itch. It's ridiculous. My hair is really curly. It was not like this. And everyone compliments me, and I'm like, oh, it's my chemo perm. I'm like, 6 rounds of chopped chemotherapy, and you can have it. I don't know. And, all of this is good conversations and important things to talk about, and I just wanted to bring up that part of mine. I'm sure I missed like 16 different things, and I probably didn't say everything I wanted to, but that's normal.
Thank you so much. So we have one question. We have one quick question from the floor, and I think anybody can ask anything. I think this is actually directed to Dr. Reski, but I think anybody could answer. Regarding the differences in oncofertility counseling offered to African Americans, what factors do you think account for this disparity, and what steps can be taken to address this?
Yeah, I think that's an excellent question. I'm not really sure what the underlying reason is. For sure, there are assumptions, whether it's socioeconomic, insurance, insurance background, but for sure having said so and having worked now for a while at LSU, that is something we have to address and improve. For sure, we are working at LSU to improve these disparities. And hopefully we will be successful. But having said so, I don't have an immediate answer why that is. Do you have any?
I don't know why. I mean, I think one of the things we could do to address it is to just make sure that our counseling is exactly the same across the board, regardless. I think it has to be regardless of not only gender, race, but also I think we make assumptions sometimes about socioeconomic status based on the way a patient dresses or presents to the office that really doesn't have to do with anything. It has much more to do with what their values are and what they're willing or want to spend their money for. So I think to standardize almost the approach to the patient and make sure that this is part of the conversation and not make assumptions about our patients is something that would be particularly important. So do we have other questions? Oh, sorry. Does this panel have anything to offer for patients who've been through extensive treatment, chemoradiation, and SCT, who did not harvest their eggs, et cetera, ahead of time? I think this one goes to Sissy or Rod.
Well, yeah, go ahead, Sissy.
I'm sorry. Yes, of course the concern is that there has been damage done to the eggs, and I don't know who asked this question, but is there any indication that there is ovarian function? And if there is not, if they're not regular menstrual periods, then there is testing that can be done to answer that question as well. Hormonal testing, looking at hormones such as estrogen, FSH, and a marker called anti-Mullerian hormone. And those can really tell you if there's any hope there, if there's any possibility for fertility related to the remaining eggs. Generally, though, so stem cell transplant is what happened. Yeah, I mean, generally the hope for functioning of eggs that are in the ovary when that occurs is really pretty limited. What we do with patients that do have complete ovarian failure is we discuss with them considering egg donation, using eggs from younger women, or of course adoption is the other option. But I think it would not be likely that there's going to be function of those eggs at this point in time, or those ovaries.
I think that it's important for the cancer survivors who are facing infertility is that, you're really in most ways no different than 1 out of 8 couples that we see who don't have cancer who are facing infertility problems. So you're not alone in the world. You're no different, really, than many of our other patients that see us for other indications. And so I'd like to, echo what Sissy says, is that we have to offer all those options. And I think too often we don't remember to think about adoption. But gamete donation, there are women who use donor eggs for various reasons. They may have lost their ovaries through other benign conditions that they've had to require surgery on. Maybe they had their chemotherapy before they thought about it, or could be counseled before they met Mr. Right, and now they've got, a spouse to consider, and he'd like to have his own biological children, and so, they want to have the satisfaction and joy of carrying a pregnancy, but even though it may not be genetically related. So we use donor eggs quite often in those circumstances, just like we do in all of our other fertility patients. So, in some ways we can't treat you a lot differently from the normal, quote, normal infertile population. So.
I actually have a
Uh-huh.
for everyone. You know, Zane and I both were told, I was told that I was going to lose 70% of my eggs and that I would be in menopause by this point. I didn't share that I do have a second child. I did the team in training marathon, the first rock and roll here, and we had a babysitter for one night, and we now have Evelyn Faye. Since everyone else was talking about sex, I mean, it wasn't like we were trying for a baby. It was kind of like, wow, okay, I didn't think I was going to be able to. We were pretty, you know, decided that we had had an only child, and here comes her sister, to her dissatisfaction. But my question is, you know, all of this is new. I entered us into a study because I want information for people later on, you know, that won't be faced with the fears that I had. How much is 100% sure that the fertility issues are caused by chemo or caused by things? I mean, I'm still not in menopause. I'm still having to do my charting to make sure that we don't, well, I may have a third, who knows? My oncologist won't be happy about that, but he'll be supportive. I don't know, sorry.
You know, I'd like to just make one other comment, and part of it was what Debbie said, and that one of the doctors said, well, I have two daughters, and if I was faced with the same decision, I would do what you're doing. You know, as physicians, we have to take whatever data is available to us and experience of others and do what we call evidence-based medicine. In other words, we have to give our patients the best information that we have based on whatever studies are available. And it's not all perfect. And what I tell patients frequently is really, honestly, there are only two numbers that mean anything to you all, and that's 0 and 100%. You either aren't cured or you are cured. And it's the same thing when you decide to make that decision. What we can do is give you the best advice we can, but ultimately it's your decision. Just like we can't predict who's going to go through the menopause, but we can say if you receive this treatment, you have about a 60% chance that you will go through an early menopause. You know, it only takes one sperm, and we call male infertility. Doesn't sound like a lot, but if a man has a sperm count of less than 20 million, he's considered subfertile. It only takes one sperm. And everybody who's done any infertility treatment has have men who have a few 100,000, and they get their wives pregnant, and yet we have another guy who has, you know, 200 million, and he can't get his wife pregnant. So, you know, numbers are great, and we have to use them to try to give you the best advice we can. But there are always exceptions, and you're always going to make your decision on what you think is best for you. Doctor, I appreciate your best advice, but I'm not going to accept that treatment. Or I do want to go with that treatment, experimental or not.
One thing I wanted to add, the challenge moving sort of ahead into the future is that cancer treatment really is changing in the terms of that it is, thank God, becoming more and more targeted. You know, having said so, the challenge will be really to see, you know, what side effects you have on fertility. Having said so, I think one important thing moving ahead we should try to improve is like with the capabilities we have now with technology, with the internet, that we should become better and improve capturing of this data and then real life sort of putting the experience and outcomes into the web and making that freely accessible to practitioners as well as to patients. And I think that's something we have to work on.
We have two more questions. And I have one kind of interesting idea that comes up from tonight. And I think it would be very interesting. Are there registries? I know you're in a study, you're a 106 study, but it'd be interesting to have the babies actually follow up in your tackle clinic. exposed babies. Does that exist?
It actually does exist.
Uh-huh.
So the most pediatric oncologists are a part of Children's Oncology Group, and there is a umbrella study, which is the ALTE 041NN1, which actually follows survivors. But there is a subset study that has come out of that, which actually follows survivors and their offspring. So we do have studies out there. This is for childhood cancer survivors that would have looked at offspring. I don't know about the adolescents and young adults, but I think that lives strong, and I want to say, even Oncofertility is looking into opening some sort of studies. But I know Children's Oncology Group they are following the offspring at this time.
Okay. Next question. This is for the patients and caregiver on the panel. Given the difficulty inherent in these experiences, was it routinely offered to you to see a counselor or therapist?
I'm thinking about this. No, it wasn't routinely suggested. At Duke, there were some counseling sessions, which I found to be not very helpful. And I say that only because I was so overwhelmed with our own situation, and then to hear about everybody else's too was very upsetting to me. It was group sessions. But no, I don't remember that being suggested very often.
Would it have been helpful? Even if it was one session that was just set up that, we set this up for you, you could choose to go or not go?
It might have been helpful, one-on-one, possibly. Mm-hmm.
And you guys?
It was never suggested, but I had to go 5 years later because I kept everything suppressed, and so I went into counseling 5 years, 96, because it was all coming out through anger, and so and I kind of quit that because I didn't want to go through the process. When I hit my 20-year mark, that's when I started thinking about talking, and so that's kind of like why I'm here right now. Okay.
I pursued it, but still could not find anyone that was, with everything and all the doctors. And my husband had excellent insurance. We still had a lot of out-of-pocket, and, therapy costs a price. I did find a social worker at my oncologist's office that I did become friends with. She was a breast cancer survivor, and she was very helpful with some things, but some things were just out of her reach. I mean, I was kind of, whenever I had to go through chemotherapy, they would put me in a separate room from all the other, because in case a bag burst, they didn't want to hurt the baby. And I also couldn't take a lot of the drugs that, the rest of them could take to clear ports. I mean, they had me running up and down the hallway one day to clear my port. And it was different. I was offered a lot of resources, journaling and different things, but I think that anyone that has gone through it, when you're in it, you're just trying to survive. I mean, you're not... I went through 3 months of laying in bed and just praying that my baby would be born and that she would be healthy. Even if I could have sat down with a counselor, I don't think that I could have talked about it. I think the most important thing would be a follow-up. Like I said, I have a 2-year-old and a 3-year-old. I don't have much time to think. Most of the time it's, potty training and everything else, and I'm so blessed to have that. And I thank God every time I look at them. And I just think that is something that is important, and that it's something that needs to be addressed later, is how you deal with the decisions that were made and how you accept and move on with your life. And you never really fully will. You live with it. It's just the way it is. It always will be. But I'm glad to have it. It's better than the alternative. I'll live with it.
Could I ask a follow-up of any of the cancer survivors in the audience or the panelists as well? Because the impression, from my perspective, my viewpoint, is that very often, for whatever reason, maybe the oncologist is put on a pedestal, or sort of he's so busy and he's worried about these concerns. They aren't the most approachable people to kind of let your feelings out with. Is there somebody in the healthcare teams that you met with that you felt a greater comfort level? Would it be the chemotherapy nurse? Would it be the social worker? Would it be the counselor? In some programs, they have patient navigators, where they maybe have cancer survivors themselves who are willing to volunteer their services to help new patients through navigate some of the things and maybe share some of the feelings. Is there a consensus, or is there some feelings among some of you about who you would feel most comfortable talking with?
It has to turn. I really felt very, it was very nice having a social worker there. She was a survivor of breast cancer, and they actually always have someone there now. But as you can imagine, my first chemo the day after Christmas, I broke down in the waiting room before I had to go back. And my mom, my primary caregiver, and I'm an only child, and this is her first grandchild. And my husband and my father were all sitting there, and I couldn't, hold it together. Anyway, she was the first person that came to me, and she sat down with me, and she helped me go through paperwork, and she helped me go through a lot of things. And even though, she wasn't in my situation, she did really just that. She was that friendly face, and the oncology nurses were too. I developed such a bond with them, and they still make fun of my husband and I because we played Uno the whole time, and he wouldn't let me win. But I still go by and see him. I bring Meg, I bring my daughter Margaret, all the time because it makes them so happy to see her and all that hard work that they put into, and how nice she is. And but that was something that I think that and I was actually upset at MD Anderson. You would think that they had a really good counselor system, but I really didn't find that. But the familiar face that always came through the chemo room and just said, "Hey, how are you doing?" And that's who I ended up meeting with.
Right. All right, one last question. One of our participants had both a brain tumor and AML, and they had alkaloid-based chemotherapy along with Ara-C and idarubicin. They've had radiation therapy, and they want to know about their odds of having affected fertility as a man. I don't know that anybody here's a male infertility expert, but y'all can take a stab at that.
Well, actually, I've done a fair amount of male infertility in terms of everything from sperm recovery through TASA, or testicular biopsies, epididymal biopsies, as well as electroejaculation in various types of patients. So, some aspects. I mean, if he had radiation to the brain, and it affected his pituitary and the ability to stimulate the testicles, we can sometimes treat that actually quite easily. So we have hormonal treatment if the gonads themselves are still intact. So if the testes are capable of responding, even though the signals from the brain have been eliminated, we can successfully treat them, and actually quite well. In terms of if we've got really significant damage to the sperm-producing cells, if there are any viable cells that we can get by testicular biopsies, we can also achieve that. And now, one of the procedures that we do in vitro in men with only a few sperm, we do something called ICSI, intracytoplasmic sperm injection, where it really only takes one sperm, and we literally inject it into a single egg. So we can treat a lot of pretty severe male factor infertility.
All right, I'd like to thank everybody for coming tonight. I'd like to thank especially our survivors. I think that the personal cost to come and tell your stories must be great and very difficult, but I think it makes everything more meaning and relative. I'd like to thank our physician faculty. I mean, just having us all in the one room at the same time and seeing each other's faces and I think it puts pressure on us to make sure that we build these bridges that I've been trying to work on. So I'm grateful for you guys for being here and your preparation for tonight. And then to all of you who came and participated, if you can at least carry the possibilities out that we've discussed, either as a provider to your peers so that they know what else is out that we can offer, as patients or as caregivers, so that we can spread the word that this is available and these resources are available here in New Orleans. I think it would be great. So thank you all for your time and attention, and to LLS for making this possible.